Today's Grand Rounds, we're pleased it's hosted by the Division of Hospital Medicine. And before I introduce our interim chair for hospital medicine, just a couple of housekeeping things. I encourage everybody to continue to attend here in person. Today we have about 25 people and about 30 online. So thank you all. Continue to attend, please, and send any suggestions on how to improve Grand Rounds to myself or Thomas Bryan. Thank you. All right. So let me introduce the chair for the Division of Hospital Medicine, Dr. Alan Dow. He is the interim chair for the hospital medicine here. He's also the director for the Center of Interprofessional Education and Collaborative Care. As you know, he's also the president and CEO of the professional education arm of our health system. And I think he was also the founding member of the Division of Hospital Medicine here in 2004. Maybe?
One of the founding members.
One of the founding members. I'm sorry. Sorry, Dr. McIntosh and others. So one of the founding members. But Dr. Dow, if you want to come up, introduce our speaker. Thank you.
Great. Thank you, Christian, and good to see everybody. So we didn't realize when we picked this day for hospital medicine's sponsored internal medicine grand rounds that it's actually National Hospitalist Day. So thank your hospitalists. And it's a well-known fact that later today, the hospitalists will lay out their Patagonia vests in the hospitalist offices, and the subspecialists and emergency medicine docs are supposed to come around and put gift cards for Panera and Starbucks into the pockets. It's a sort of a tradition, very well known in hospitalist world. So we look forward to that in your gifts. So thank you for all of that. So thank you for being here. I decided to invite an emergency medicine doc to give the hospital medicine grand round, so please forgive me. But our speaker, Dimitrios Papanagnou, is just an excellent speaker who's doing some great work around uncertainty and how we think about clinical thinking. And having heard him speak a couple times, I thought he'd be great to come speak with us. He is an emergency medicine doc. He holds several leadership roles. He's the vice chair of education at Jefferson in the Department of Emergency Medicine. He also has an associate dean role for faculty development, an associate provost role for their campus, thinking about faculty development and interprofessional work that he does there. He's been funded by AHRQ as well as a bunch of foundations to do his work around clinical thinking and clinical decision-making. And it's just a tremendous scholar, thinker, researcher, and educator. And I think you will enjoy what will prove to be a provocative experience for you. I think will help us think a lot about the work we do and how we do it. Dimitri.
Thank you. So thank you so much for that incredible introduction, and thank you for welcoming me, an emergency medicine physician, on National Hospitalist Day. So happy National Hospitalist Day. Today, I'm going to talk a little bit about uncertainty in clinical practice, something that we know, we lived through, we reflected on. I'm going to bring an educational spin to it. I'll bring in a research spin to it. But one thing I want to clarify is that I'm not an expert in uncertainty. In fact, I'm learning a lot about it every day and learned a lot about it this morning in my conversations with many of you. The truth of the matter is that there are a lot of amazing researchers and educators nationally doing great work. And what I hope to do today is really connect some of those dots and bring in some of the research that we're doing. So thank you for that introduction. I am an emergency medicine physician by training. I have been able to really step into this uncertainty world and study it through support from the National Academy of Medicine and the Macy Faculty Scholars Program. So that's my only two disclaimers. So the good news for all of you is that I came here from Philadelphia with a lot of money. Now, each of you will get a satchel of this money. So just imagine me here with all these satchels of cash, and each of you gets one, right? What a hospitalist day that is. So you have two options. Well, you have one task, and that task is you have to invest in one of the two banks here in front of you. So you have the option of investing in National C Bank or National U Bank. So you do some intel, but you don't really have access to the financials. You don't know much about the ROI, the return on investment that you get, but you do some digging and you find out a little bit about their philosophies. So you find out that National C Bank, their mission, Their mission in terms of their daily operations is to completely eliminate uncertainty. They hate uncertainty. It makes them uncomfortable. And to this effect, they've instituted strategies and processes to reduce the uncertainty in every single banker that works for them. Okay, so they hire experts that have content expertise in lots of different things. So that's option one. Option two is to invest your money, this amazing satchel of cash, in National U Bank. Now, this bank's philosophy is to amplify uncertainty, just to live in it, to celebrate it, to talk about it, right? They don't want their employees to have requisite knowledge and or expertise. In fact, they might hire somebody that hasn't really worked on a business deal before to handle your money, right? And what they want to do is they want their staff to confront these unfamiliar situations, learn in the moment, and persistently face uncertainty. Close your eyes for a moment, some visual imagery here, and think about which bank you're going to choose to invest this satchel of money in. So hopefully you made your decision, right? What if I told you, and you might have that crystallized in your mind, but what if I told you that Bank U brings in double the revenue yearly than Bank C? What if I told you that this mindset of celebrating uncertainty, bringing it to the forefront, living in it, is what happens at Google and Apple and Xerox? So there's a great book by Mitchell and Wortham called Bullish on Uncertainty. And this is a play to the term bull market. And for those of you non-finance people in the room, a bull market describes a positive market, an optimistic market, a market where the prices are high, where things are going well, right? As opposed to a bear market, one that connotes pessimism, very minimal sentiments around investment. And what she posits is that in this case study of these two banks, the bank that embraced the uncertainty has always been able to engage in a very bullish market. A really, really great read, an easy read, but we're not in finance, maybe some of us are. But think about what this mission, what this philosophy says about culture, right? Just reflect for your moment. What does that look like? And as you reflect on that, think about the culture in which you work, learn, and take care of patients. And what does that culture look like? Is it a culture that celebrates uncertainty? Is it a culture that welcomes saying, I don't know? Is it a culture that really promotes curiosity over certainty? So that's sort of the fundamental cultural question I have in mind, because that really ties into psychological safety. And the way that we navigate uncertainty in clinical practice and we teach those skills to our trainees is super contingent on that psychological safety. So as you think about Bank U, that's uber successful, does very well, compare and contrast that to our respective cultures. So my goal today is to bring this back into healthcare and talk about a very unique workplace. And that's the workplace where we work and where we learn, the clinical learning and clinical working environment. And to that effect, I have three very specific objectives. The first one, we can co-create together, right, to describe the complexity and the uncertainty of the clinical learning and working environment. This is something that we can perhaps share and co-create what that looks like. Then I want to share some frameworks that can offer us a better understanding of what working and learning in this environment, in this unique workplace looks like. And bringing in the research and education, I want to share a few educational strategies that can help us prime trainees, students, residents, fellows, junior faculty, ourselves, to get them to learn authentically amidst this uncertainty, a type of learning that we call informal and incidental learning. Informal learning because it occurs outside of a structured place, like a classroom, and incidental learning because it's a learning that happens that is coincident with solving a problem, for which the primary intention is not to learn. Learning something because you tried something and a byproduct of that was learning. Now, I don't espouse myself to be an expert. I really sort of stalk people on Twitter and learn about them and set up meetings and sort of see how their research questions can inform our research questions. A lot of this information has really boomed over the last 2 years. I think we learned a lot from COVID. And I'm going to share some examples from how we address the pandemic and how we can learn from those to implement programs in practice. This photo taken from a New York Times article around the height of the pandemic in 2020. So the first objective, the complexity and the uncertainty of the clinical workplace. There is a lot of uncertainty in clinical practice. We know this. Diagnosis cannot be made. Sometimes treatment recommendations may be at odds. And most of the time, the social and the structural determinants of health will complicate management. And that's intuitive. You think about the way that medical education has been designed. We've always trained, we've always rewarded certainty. Go back to your formative training in undergraduate medical education, for those of you that are physicians in the room. Right? What is the correct answer on this multiple choice question? What is the correct diagnosis on this simulation? What's the correct set of answers on this OSCE, this objective structured clinical encounter? Right? So we train our students for that, and they hit the clinical environment, and there's this cognitive dissonance because what happens in practice, what happened in theory isn't happening in praxis. And that's what we are seeing. So what we're really trying to do is sort of, with backward design, find experiences that can embed them in this type of thinking, conversations that we had a little bit this morning. And here's the problem. The clinical training environment rewards those who give correct answers, right? What is this diagnosis? What am I seeking here, right? And because this has been propagated, uncertainty over time has been shamed. Will Bynum, somebody from Duke, is doing amazing work on shame research, but this is a phenomenon. It's been well described in the GME literature, but uncertainty is shamed. And what residents and trainees are doing is they're not asking for help when faced for uncertainty. And why is that? Well, they don't want to be seen as weak. And because of that, barriers to disclosing uncertainty are propagated. So when faced with this uncertainty, there's this propensity to do what? There's a propensity to do more to resolve uncertainty. This might be observations that you made in others or yourselves, where if you don't know something in a specific clinical scenario, taking care of patients, you might do more. What do I mean by this? With taking care of more patients, with taking care of patients in less time, right? There's this propensity to do more, to order more, to do a little bit more of an investigative workup, driving up costs, maybe referring patients to services that might be unnecessary. Perhaps if you're in the ED, admitting more patients because that ED provider is just a little bit uncertain with what's going on in his or their patient at that time, right? And then what we see are delays in care and ultimately delays in harm. And the unique factor about this is we live in an age where answers are literally at our fingertips, yet this is the type of workplace that we will be learning and training others to learn and thrive in the long term. So I mentioned this, but we learned a lot during the COVID-19 pandemic. So taking this back to the clinical, right? When we had to unlearn practices that we were doing, when treatment guidelines were changing, when protocols were changing, when there were shortages in PPE, when the physical environment was being reconfigured almost daily. So we learned a lot from COVID, and we learned that uncertainty can sort of fall within several domains. Cognitive uncertainty. I don't know what to do at this specific time because I just don't know much about this virus. I just don't know how to take care of these patients. The emotional uncertainty that comes with that, right? This is how I feel. This is my reaction to uncertainty. And the ethical considerations. Which patient of mine gets that last ICU bed? Which patient of mine gets that ventilator? These are tough conversations that we really don't stop to think about, especially in trainees who are facing this head on. And in medicine, I think we know this very well, right? We encounter uncertainty when it's difficult for us to define a disease, to explain it and make a diagnosis, to find out what those treatment options are, to make a prognosis and align everything with our patients and really eliciting their preferences and ultimately decision-making. And a lot of this is coming out within the diagnostic space. So when we're talking about uncertainty and you do a good scoping review of what's out there, it's really around diagnostic uncertainty and decision-making. So when we think about defining what uncertainty means, a lot of definitions have been offered, but this is one by Lee et al. Coming from New Zealand that I really like a lot. Uncertainty is defined as the dynamic, subjective perception of not knowing what to think, feel, or do. Not knowing what to think, feel, or do. So, and this can be caused by one of several things, right? There could be ambiguity. Things are just a little murky at the time, right? There's lack of reliable, credible information. You need some more information. You need some time to problem solve and emerge through this ambiguity and make things a little bit clearer. That uncertainty might come out of probability, right? Things might be random. They might not always behave the same. There might be some uncertainty over future outcomes. And then the work itself can provide that uncertainty because the work itself is complex, right? It's very unique, it's very specific, and there are features of that information that would limit understanding. So Hill et al. Did this really great analysis of tolerance of uncertainty and understanding that uncertainty can be caused by either probability, ambiguity, complexity, and then you sort of get this response, which is uncertainty, that leads to all these downstream cognitive, emotional, and behavioral aspects. They propose that there are moderators, things that we could do to address that uncertainty. And given that I sit in the med ed space, sound medical education would be appropriate. There is one thing I want to clarify. We talk, and again, we spoke about this in some of the conversations this morning, but we frequently talk about tolerance of uncertainty, comfort of uncertainty. Sound educational programs are not going to rewire our brains to be more comfortable with it. It's like taking somebody who's an introvert and making them an extrovert. Those are just simply preferences for how we want to engage in the world, take in information, behave with that information, right? But what we can do is create experiences and provide learners and trainees with tools to navigate uncertainty in clinical practice as they arise. And that is the overarching picture of what we're doing in our medical education program. So much so that at our medical school at Jefferson, the Sidney Kimmel Medical College, we've built in 2 specific medical education program objectives, or MEPOs. MEPOs are things that we sort of commit to sort of say that by the time a student graduates medical school, they will be able to do these things. And it's not like we have a really long list of these things, but we have to prioritize what's important. And to this effect, we prioritize 2 of these to speak to uncertainty, to get our trainees to recognize that uncertainty is part of clinical healthcare, meaning to get them to appraise their uncertainty, not be comfortable with it, not be tolerant of it, but rather to sort of acknowledge it, appraise it, diagnose it, think about it, and then be able to choose intentional tools to help them navigate that uncertainty in real time. So that's one MEPO. And the other MEPO is essentially what I just said, but by responding through the use of tools and skills with this uncertainty. Now, I'm presenting this to you as if this is new science, as if this is new information. The truth of the matter is, this has been going on in pediatrics for a very long time, which I'll share. So what does this mean for us? Well, we get our students to sort of think about their management style and how they lead and how leadership could look different in this uncertainty. Uncertainty itself can be seen as risk, right? One's relationship with risk, one of probability, right? Do you want to take a chance on X in the setting of Y when you're dealing with this uncertainty? And that perception of risk, that perception of how you might behave in Vegas when you have this satchel of money that you decided not to invest in those banks, but rather take with you to, maximize your outcomes in Vegas, might be different based on your risk positionality. We get them to sort of think about uncertainty and aligning this with patient goals. And this is where we bring in communication and being able to communicate uncertainty, communicating diagnostic uncertainty. In our research, we found that emergency medicine trainees, when presented with diagnostic uncertainty, would oftentimes approach their patients at discharge at a major, important, critical transition in care by knock, knock, good news. All your tests are normal, nothing is wrong with you, you can go home now. And that was sort of the prevalent way in sort of speech syntax that a lot of our residents were training, highlighting a curricular need to create programs, to create scaffolding for those conversations. Numeracy, numbers. We do a really great job at presenting our patients, our learners with evidence-based medicine, but how are they able to explain this information, sensitivity, likelihood ratios to their patients at the point of patient care? We get them to respond a little bit to their uncertainty by thinking a little bit about that. There are a lot of great scales out there on tolerance of uncertainty, on comfort with uncertainty. We don't use these for any summative purposes at all. We just use them for the point of reflection, just to get them to understand a little bit more about what their relationship with uncertainty is. How are they supporting their patients during times of uncertainty? Are they providing them with resources? What do those transitions in care look like? And ultimately with the hope of improving their responses to it. Now, earlier I said that this is not new science. This is not new educational intervention. Pediatrics has been doing this for some time, where they've taken milestones development and they really fleshed these out developmentally, beginning from early level milestones to really sophisticated ones where they can actually do what we want them to be doing, to appraising the uncertainty, to manage it, to seek out resources, to discuss it, to be open and transparent with their patients. And a lot of this has informed the backwards design of what we want to be including in our curriculum. So a lot of stuff that we know, just want to explicitly put out there that a lot of people have thought about it, and sort of presenting some of the challenges that we encounter when dealing with uncertainty, and specifically looking at uncertainty from the lens of education and training. So my second objective, I want to share some frameworks that can help us get a better understanding of how we can talk about uncertainty, right? Because it's a little bit deeper than that. It requires a little bit more unpacking. And by doing that, I think we really need to take a critical look at what learning in the clinical learning environment looks like. So apologies at the beginning if this gets a little theoretical. I promise there's a rationale for this, because it's, with any good educational project, you need a conceptual framework. And I just want to just share with you that framework. Earlier, I mentioned that the work is complex, right? And this word was chosen with intention. So complexity, complex adaptive systems all play into this, right? Whether you're talking about banking or our immune systems or our hospitals, the emergency departments, these are all complex adaptive systems, right? Systems that contain multiple parts that interact with other parts that could be influenced by individuals and the agents within them that could be influenced by time. And it's the sum of all these multitude of interactions between these agents that will give us that net result of what we see. So a lot of what we've done, a lot of what has sort of scaffolded our thinking around creating training that prepares trainees for uncertainty in clinical practice really comes from complexity theory, really comes from understanding complex adaptive systems, really comes from the Conceptual Framework. The Conceptual Framework depicted here, it's a Welsh spelling. It actually means habitat in Welsh, was coined by David Snowden in the 90s when he worked for IBM to sort of explain what habitat someone is in when they're working through something that they do not know, when they're working with uncertainty, to better understand how we can sort of say, I don't know in that specific context, and how that can help us seek the solutions, seek the tools that we require. So this is pretty simply. He proposed that there are 4 quadrants. An obvious simple quadrant. This is the quadrant we love to be in. There's one answer that everyone will agree about. This is the quadrant we want to be in when we get asked a question, right? There's a best practice here, and it's universally agreed upon that that is the best practice. Complicated, where this is where good practices live in. Things are complicated. There could be more than one right answer, right? This is the home of what we like to call known unknowns. This is the home of known unknowns. I know what I don't know, and I can, because I know what I don't know, I can figure that out. Things might be murky, things might be ambiguous, but when you're in this quadrant and when dealing with things in this quadrant, you can sort of figure things out and emerge through this and hopefully move clockwise into the simple quadrant. Complex quadrant is where that cause and effect relationship is blurred. This is where there are unknown unknowns. This is where there are unknown unknowns, where we don't know what we don't know, right? And this is where you need to probe with the system, look at the problem, poke at the periphery of that problem, do some trial and error to collect some data. And there's chaotic, where cause and effect are completely blurred, and you just need to take action and not really probe it. You don't have the time or the bandwidth to probe that system. So this is a picture taken online from Dave Snowden's website. But given which quadrant you are in, you're going to be acting differently. You're going to be behaving differently. You're going to be engaging with that system differently. And it's for that reason that this is a sense-making framework. This is a sense-making framework that we've brought into our educational programs when we conduct a debriefing, when we conduct a critical incident briefing or a root cause analysis. And I'll explain that in just a moment. So in that obvious and simple quadrant, right, this is where you sense information. You take in information that the environment gives you, you categorize it, and you respond, right? I'm going to use these very, very hyperbole examples to sort of make this clear. But say you're checking somebody's blood pressure, right? That information that you're sensing are blood pressure readings, and then you're categorizing it. Is it high? Is it low? Great. If it's high, I'm going to treat it, right? Very simplified, but just want to make that clear. So there's one best answer. Everybody can agree with it. There's unison here, and people feel comfortable in this obvious and simple quadrant. In that complicated quadrant, you're still taking in information. You're still taking in data and making sense of it. But in this case, it's not so easy to sort of categorize that information. You need to play around with that information a little bit more. You need to analyze that information, and only then can you respond. So in this case, another simplified, maybe oversimplified scenario is a first-time diabetic that presents to you for care. Right? So yes, you need to treat it, but the way that you treat it might be a little bit more nuanced. You need some more information. You need some more history. You need to do some more digging, right? And in that case, that analysis piece is very, very clear. You know what you don't know. You can figure things out. And in both sides, on the right side, the cause and effect relationship is pretty clear. The complex is a little bit different. In the complex, if I do A, will I get B? Will I get C? I just don't know. Right? For me to do that, I need to probe the environment a little bit more. I need to try things out a little bit more. I need to create some data points. And once you create those data points, then you can sort of sense those data points and respond appropriately. And the best example here that I can think of right now is the COVID-19 pandemic at the height of it, right? Between March to April of 2020, when practitioners had to really engage with the system and try things and get many failures to sort of generate that data. It was complex, right? Especially in the setting of changing configurations, changing policies and shortages in the way that we work normally. And lastly, the chaotic, where there really is no time to probe and try these minimal experiments or sense data because it doesn't exist. We just need to act. And as an emergency medicine physician, example in this domain really become clear. An example that comes to my mind is that Northeast Corridor Amtrak crash that happened right outside of Philadelphia in 2015 that we had to respond to, where there were patients that were entrapped and we needed to extricate them, and the decisions to amputate had to be made in the moment. And then, going through these and looking at that data afterwards was the only way for us to respond in future events. So simplified scenarios to explain this framework that we feel is very influential in guiding some of the things that we've done as a conceptual framework. So again, apologies for being theoretical. The last theory I just want to introduce here is that regardless of one more thing, I'm going to back up. Not everyone in a team needs to be in the same quadrant, right? So I could be in a team and we could be using this, and for somebody, the work might be complex. For somebody, the work might be complicated. For somebody else with lots of experience, it might be the simple and obvious quadrant. This is a sense-making tool for individuals just to make sense of their uncertainty as they're grappling through it. I want to posit that within each of these quadrants, there's a lot of learning that happens. So regardless of if things are simple to complex or complicated, there's going to be a lot of learning that takes place in each of these quadrants, which gets you to more ordered quadrants. And we talk about this and introduce this as informal and incidental learning. And this is a paper that we wrote recently where we define what that means. Informal learning, meaning the learning that happens informally, outside of a formal setting, outside of the classroom, most likely in the workplace, and incidental learning, the learning that happens that happens when that is coincident with solving a problem. Marsick and Watkins, who are two of my research colleagues and mentors, have coined this and really studied this in the organizational world, right? Where there's a trigger, you respond to this trigger, but you have to interpret this trigger in a situational context. This requires you to sort of step away and employ that growth mindset to examine alternatives and think about different solutions. And based on that, to acquire the knowledge and skills to implement. You implement those solutions within that context. You then stop and think, well, what were the consequences? Did I anticipate these consequences, or were they unanticipated? What were the lessons learned there? Reframing this context and then giving you this muscle memory, this new information to react to a new trigger. For those educators in the room, you might say, Dimitri, this sounds very much like the Kolb learning experiential cycle. And you are correct. For those of quality leaders in the room, you might tell me, well, this really sounds like PDSA and Plan, Do, Study, Act. And the truth of the matter is that these are all very similar models. But what we like about this one is it's based on observation of real teams with steps that may not necessarily be in this order, but steps that are tangible to the process of learning informally and incidentally that we can actually tether specific educational experiences to. So again, regardless of what quadrant you're in, there is that informal and incidental learning cycle that takes place within each of these quadrants. So after the pandemic, we really wanted to understand better how teams, clinical teams in the ICU upstairs and the ED downstairs emerged through the complexity of the work that needed to happen, through the uncertainty of the work that needed to happen. And we conducted a critical incident analysis of frontline physicians during the pandemic. For those of you that are not qualitative researchers, I was not prior to the study, but if you want to engage in qualitative research that is fun, that is informative, and is very powerful, allow me to introduce you to critical incident technique. So this is a qualitative study, qualitative methodology that looked at narratives of physicians asked to share a critical incident that they worked through during the height of the pandemic. And I'll explain what a critical incident is. So what we did is we recruited emergency medicine and ICU physicians that worked specifically March to May of 2020, and we employed the critical incident technique. Now, this critical incident technique is really specific to a question and that framing question. And for us, that question was, think about a time when your interprofessional team faced significant uncertainty within daily clinical work during the pandemic. And oftentimes people would say, yeah, it was really hard. I was taking care of patient A and patient B. We're like, no, really hone in on one incident. What comes to mind? And what you're doing in that interview process after training your team and after using a really good protocol, you're zooming in, almost like zooming in on a picture, right? Zooming in more and more and more until you can see all those pixels. Who was there? Tell it to me as if it were a play. Where were you situated? What was the environment like? How does this environment differ from where you've worked beforehand? What did you need? What did you have? What did you learn? How did you feel in the moment? And these are sort of the guiding questions that really get us to capture really awesome, really unique, really robust narratives, really robust critical incidents. And this whole concept of critical incidents comes from one of the authors that I really like, Stephen Brookfield, that talks about transformative learning, but a little bit more on that a little bit later. And then what you do with these incidents is that you have to restory them, because as humans, we always tell stories in a very haphazard order, especially as they're asked, and we had to restory them and put them in order in a chronological account using our participants' own words. And then what we did is we looked at this data, we looked at these restoried narratives in two ways. For the qualitative researchers in the room, if you have a better way of explaining this, please raise your hand and chime in. But we looked at things deductively and inductively. So deductively basically means that we looked at this data from the lens of informal and incidental learning. We looked at this data from the lens of this theoretical framework. Remember that theoretical framework with all those steps around? We look specifically at this data to sort of see, was there this step there? Can these actions be considered in this step, and this step, and this step? And that's kind of what we did. And that the model that we used was this Watkins and Marsick model of informal and incidental learning. And we wanted to specifically identify what were they doing that exemplifies this step of the model. And then we were essentially categorizing them into patterns, assertions, and sequences. So a typical example, this is one of our incidents. This is a respiratory example. So that trigger for one of our participants was a young COVID positive patient who appeared very healthy, was walking, was talking, but had really unstable vital signs, had a pulse ox of 60%. And understanding that trigger in a situational context, that participant really spoke about how difficult it was to manage that hypoxia in a patient who was just so comfortable, right? And then allowing them to examine alternatives. What can I do here? What are my options? I'm not going to knee-jerk reflexively respond doing what I did in previous times, but rather, what are my options here? Do I intubate this patient? Do I support this patient non-invasively? Right? And as you're thinking about that, to sort of think about, well, what additional skills do I need to acquire? And what we saw in several is examining information, anecdotal information that was shared on social media in China, in New York City, in Italy, and what were other people doing? Taking some of that information, critically appraising that information, and implementing solutions that ultimately made themselves into protocols. And then looking at specific consequences, both intended or unintended, like wishing a specific intervention, like intubation, was not performed. Extracting next steps and lessons, and in sort of realizing that no matter what will happen during the height of this stage, obviously it's easy to look back and call it the height of the pandemic, but to sort of say that with all COVID positive patients presenting similarly, we're going to expect different outcomes. And there is that randomness, there is that probability there is a complexity in that work. And then ultimately to reframe context, to really think about how we need to reevaluate previous strategies and unlearn and co-create new knowledge to behave differently when that new patient comes in who appears well but has unstable vital signs. So we did that deductively, looking for elements of this theory. And then what we did is we just steeped ourselves in this data just to sort of see, well, what emerges? Let's put this theory aside. Let's look at this information and what content, what things speak to us in this information. So we took an inductive approach, right? And with the inductive approach, we just wanted to see what new things were we seeing. Were there any patterns across these transcripts? What assertions are we making about their stories? And are there themes that we can organize to explain what they shared with us? And this is the conceptual framework that will be published in academic medicine in a few months. But this is what we found in our inductive analysis, that, physicians being at the center of this sort of pandemic really were managing uncertainty that straddled four contexts: relational uncertainty, working with their interprofessional peers and their colleagues, the situational context of not knowing a virus and how things were changing almost all the time. Speaking of changing, the physical context and how the physical context differed, for whether it was physical or whether it was something that impeded their ability to work because they were wearing a PAPR and they couldn't communicate with one another, and they accepted that at face value. I'm going to this room, communication is going to be dimmed. I won't be able to normally behave the way that I'm going to behave. So that physical context. And then the emotional context, right? How are they feeling in the moment? And how is that affective processing of this work affecting their decision-making? And to that point, the unique thing that we saw was across all of these, there was this decisional burden. And this decisional burden really was combated or was supported by various specific observations that we observed, observations that we categorized as patterns for decision-making and patterns for learning. And that patterns for, and you'll notice that they are sort of connected, because learning led to decision-making, decision-making led to learning, but we took a deeper dive and we were able to name specific things that were happening that allowed us to sort of think about specific skills that we could potentially go back and ensure that we are building into educational experiences for our trainees. Simplifying a problem, looking for patterns, cross-checking information, where there was more cross-checking happening than there was previously before during practice. Trial and error and poking at the periphery of a problem, and not only gathering alternative sources of information to create new knowledge, but how do you appraise that? How do you fact check that? How do you assess for its validity? Right? And these are just a few things that we found, right? The increased awareness of others for decision-making. Again, these were physicians that we were interviewing that were leading teams, but we found an increased reliance on nursing colleagues, more so that in every single transcript, each physician commented on the need, on the importance of having nurse colleagues there to share what they've accrued as knowledge to help them. The permission to actually have people interrupt their thinking, to question actions, to bring in alternative sources of evidence information, the permission to do trial and error. All important observations that we found in our study. And this really doesn't differ much from another study actually by Halou et al. And I believe Dr. Halou is a pediatrician here at VCU, but really great paper that did a scoping review of all these themes out there, and essentially found that there needs to be sort of this metacognition that I'm uncertain right now, classifying that uncertainty, considering your perspectives on uncertainty, and then ultimately, how do you resolve that? So very consistent to other models that are out there. So some frameworks for us to better understand uncertainty. So understanding that and understanding what we learned during the pandemic and really honing in on specific skill development, can we identify, and now here's the kind of educator in me, how can we inform educational experiences that can prime trainees for informal incidental learning, right? How do we expose them to it? How do we get them to observe it? How do we get them to reflect on it to better navigate uncertainty in clinical practice? Right? So why the need for curriculum? Well, we found that there's a lot of cognitive dissonance that happens in students when they transition from the preclinical to the clinical. And this has been observed and heavily published. A colleague of mine, Lakshmi Shantosh, who's an intensivist at UCSF, wrote this really great paper, 2023, on teaching the science of uncertainty, where she and her team sort of identified 5 different domains in which educational experiences can be categorized, right? What are some things that we can do to get our trainees to recognize uncertainty? What are some things that we could be doing to get them to manage it? What are some things that we could be doing to getting our learners to communicate uncertainty? How do we get our learners to understand that uncertainty can be normalized, whether it's within their team and in the face of patient care, or normalizing that uncertainty with the patients that they're taking care of? And how are they discussing that uncertainty? And this was really a great framework for us to think about, are we doing these things? So where does a lot of this live in our curriculum in our medical school? I run the health system science curriculum. The health system science curriculum, the health system science movement has really been pushed by the American Medical Association over the last 5 to 6 years. It's this emerging science that complements the basic science and the clinical sciences, but essentially it gives them the skills, those implicit skills that we just expect them to learn in the hidden curriculum to navigate really complex, really uncertain complexities in the clinical environment. So this is our curriculum at Jefferson. It's represented here as a rainbow. It's a 3-phase curriculum. We recently moved from a 2+2 curriculum, which is preclinical and clinical, to a 3-phase curriculum. Phase 1, really no different from a 2+2, but phase 1 is all case-based learning. So we don't have any lectures. Well, we have a few lectures, but we have a CBL program where the entire curriculum is mapped to cases. Each week has a case. Our students meet twice a week to discuss the case, discuss their learning issues, and everything is tethered to those cases. Phase 2 is in year 3, and that's where our clerkships live. And these are all the clerkships that are in phase 2. And then in phase 3, our 4th year of medical school is where we are preparing them for residency according to their area of interest. And we have different categorizations of how we're training our students. So these are the threads, and they're called threads because they don't just happen in phase 1, in years 1 and 2, they happen longitudinally. So where every learning objective that happens in our curriculum is linked to all of these elements, including health system science. So it's through health system science that I was able to sort of, just like you're kind of sneaking in the kale or the broccoli into the smoothie, that's where I was able to sneak in a lot of this uncertainty work. And what health system science does, for those of you that are familiar with HSS, it's analogous to that iceberg model, right? So at the tip of the iceberg is the care that we provide to an individual patient. That's what we can see. That's what we can measure. That's what we get our feedback on. But that care that we bring to the bedside is influenced by so many things. The social determinants of health, the structural determinants of health, population health, healthcare values, current events, systemic racism, leadership, teamwork and collaboration, informatics. All these things are embedded into what happens at the bedside. And HSS essentially talks about, it covers all of these contexts. And this is sort of our framework for that, borrowed from the AMA. We wanted to also speak to our students authentically. We wanted to ask them, when you stepped into the clerkships for the first time after you left the classroom, what was that like? Here we are trying to make a curriculum, trying to design, trying to inform a curriculum that can prepare you for uncertainty in clinical practice. What can we learn from your experiences to have better prepared you? And our goal was to identify curricular elements that best prepared students for these situations. So things that they've been through already, things that we could potentially amplify and overrepresent in our curriculum, in addition to soliciting suggestions of things that we should be doing that we weren't doing, and to find out, are there people nationally that are doing this well? So this is an observational cross-sectional study. We have a very large class. We have around 280 to 290 medical students per year. Yes, 280, 290 medical students per year. It's incredible. We talk about that offline. But we wanted to examine correlations with specific elements of uncertainty in terms of how prepared they felt for uncertainty, how confident they were with communicating uncertainty to their patients. Were they able to build rapport with their patients during times of uncertainty? And then also, how did uncertainty affect their well-being? What was that like? And there are certain things that came up, some that were really, really statistically significant, some pedagogies here that are worth mentioning, but clinical team debriefings were really high. The case-based learning curriculum was also something that was highlighted. Journaling in the humanities, we do have a humanities curriculum, and they appreciated elements of the humanities. And in terms of what they wanted to see more, what they saw maybe haphazardly once in a blue moon was role modeling by faculty, preceptors, educators, supervisors in the clinical environment, how they would handle that uncertainty. So seeing that, demonstration of communication styles and communication patterns for how to communicate to patients during times of uncertainty, and storytelling. We have these story slams that take place once every quarter at Jefferson, and it's a university-wide thing where anybody can do it, from our College of Nursing to our College of Pharmacy. It's not curricular, it's not co-curricular, it's not extracurricular. They're just these things that we just invite students to, and they found these to be so powerful. So that was a really helpful starting point for us to sort of build this in. Another thing that we found was there was this association with self-compassion. So self-compassion is a relatively new field. Neff et al. At the University of Pennsylvania have studied this, but we wanted to see what is the association is there an association between self-compassion and intolerance of uncertainty? Now, I hate always going to intolerance of uncertainty because your brain always has to flip things, but the reason we use intolerance of uncertainty is because the intolerance of uncertainty scale is a pretty good validated instrument to sort of talk about that. It has good reliability, good construct, all that jazz, very good. So we use it, but we always have to flip this. So what I'm saying here is when students demonstrated a high level of self-compassion, they had a low intolerance of uncertainty. So flipping that, with a high self-compassion comes a higher tolerance of uncertainty. Now, again, this is just a correlation study, just to put it out there, but there's a lot of work in progress that's really taking a deeper dive in self-compassion to better understand what could we be doing in one of our threads. If you notice, we have a wellness thread to really build on skills that reward self-compassion. How do we do that in the medical education program? So some examples of what we're doing at our shop. This is a great scoping review by Patel et al. It came out fairly recently, but what they did is they took a really, really broad look of all the different pedagogies and educational experiences out there that have been published that are addressing uncertainty and specifically tolerance of uncertainty, and they thematically organize things by cognitive uncertainty, emotional uncertainty, and behavioral uncertainty. Don't pay any attention to the numbers in the circles, and numbers in the circles don't necessarily mean the number of studies they found. It's just the reference to it's the reference to the study that is typified there. And the colors talk about whether or not a positive or a negative response was found. So it was nice to see that our work with our curriculum, with our student-generated data, sort of triangulated with, you know, a larger body of work. Like I said, all of our content is embedded in our health system science curriculum. I highlighted this study where we sort of thought a little bit about informal and incidental learning, where we took all of the stages of that Marsick and Watkins model, the triggers, interpreting that trigger in a situational context, acquiring the required requisite skills to problem solve, and we identified educational strategies that link to those. And we wanted to make sure that those were being represented in our curriculum, whether it was preclinical or most of the time in our clerkships. In terms of how do we train our learners to talk about uncertainty, I mentioned earlier that we have a case-based learning curriculum. Again, for those of you that don't know what that looks like in an undergraduate medical education program, we use the Maastricht model, where 6 to 8 students come in on day 1 of CBL with a faculty facilitator. They get their case, they talk through the case, the faculty facilitator doesn't really do much talking. They do a lot of the talking. They navigate and they identify learning issues, roadblocks, and they capture those learning issues as the case unfolds over those 2 hours. And then following those 2 hours, they look at those learning issues. They get rid of some because they might have Googled the answer and that was easy. Some still remain, some can be consolidated. They divide up the learning issues amongst themselves. They come back 48 hours later. They present those learning issues to their colleagues and they dive back into the case. So we love CBL, our students love CBL. So we thought, why don't we just make some of these cases not have a diagnosis, especially in year 2, and have students sort of reconcile what those transitions in care will look like. This was met with some discontent with our students because they are frustrated by it, as well as our educators. So we are navigating some of the hiccups here, but from having had this many cases without a diagnosis, we had to truncate that a little bit, but we are optimizing that in our curriculum. In phase 2, which is our year 3, where our students rotate through a series of clerkships, we've asked every single clerkship director to embed one of the MIPOs on uncertainty into the objectives that they're writing for our curriculum. And that takes place in peds, in family, in emergency medicine, in neuro, in IM, in all of our clerkships. One of the things that we saw was debriefing, and every single student that graduates from our medical education program receives a training and the deliberate practice to lead a debriefing. So for those of you that are simulationists, that know the debriefing literature, anybody can start these conversations. It doesn't necessarily need to be the senior most person. It doesn't need to be one specific type of profession. Anybody can initiate these. And we immerse them in interprofessional learning experiences where we prompt them and give them feedback, and they deliberately practice it again in subsequent times to lead debriefings of critical incidents. So much so that our goal is really to make this a habit and a skill that they can rely on when they go into independent practice. Appraisal of uncertainty is something else that's really important, right? Getting them to sort of acknowledge and share and communicate this uncertainty as they're sort of making sense through it. And here is that Cunningham framework, and we've incorporated the Cunningham framework into our simulations. We've brought in the Cunningham framework into how we debrief simulations, and we've brought in the Cunningham framework into phase 3 with experiential sessions that unfold over time that I'll describe in a moment. And here it is. So in year 3, we have a workshop. It's a longitudinal case of a patient living through the trials and tribulations of navigating a healthcare system. Right? And they have to work in teams to problem solve amidst this uncertainty for the patient that they're taking care of. We get them to diagnose the type of uncertainty that that case is presenting at that point in time. We have them categorize where they would be, where their sense making is by the Cunningham framework. And then we have them cite specific health system science tools to navigate that uncertainty. And that is something that we do once every quarter with our 4th-year medical students. Another thing that I mentioned earlier is around communication and modeling that communication is how are we training our learners to communicate uncertainty. I shared earlier that it's not happening in training. We found specific phrases that our physicians are bringing in to that patient-physician communication that we wanted to remedy. So when an AHRQ grant came out to apply for funding to use simulation, we decided, wouldn't it be great if we put together a simulation-based mastery learning program to train them how to communicate diagnostic uncertainty. And we brought in patients as content experts, patients across the board, including from the city of Philadelphia to really tell us what they would like to see in those conversations, as well as program directors and sociologists and linguists. We also looked at the literature to find out what was out there already. A lot of this is around the disclosing bad news literature, but there is some stuff around communication. So we brought that in, and then we did some standard setting, where we had patients sort of figure out using an Angoff method to find out what would be a minimum passing standard. And that minimum passing standard for our residents was determined by patients and by program directors nationally. So, and here it is, essentially, it's really explicitly stating that I don't know what your diagnosis is. It's explicitly normalizing the uncertainty that is part of ED care. It's explicitly stating what the goal and what the rationale was for that patient encounter in the ED, right? What was our role? What was I looking for? What was my plan to rule out? And this is something that we train our residents with. This was a collaborative study that I forgot to mention between us and Northwestern, but we've taken this and we've embedded this in our UME curriculum. So our trainees are learning how to communicate diagnostic uncertainty before they graduate with us. But for all of these things to happen, the PBLs, the simulations, the interventions, right, the reflections, the milieu in which this happens is really important, which is why I started off the session by getting us to think a little bit about culture and what the culture must be like at Bank C versus Bank U. And the psychological safety really needs to be key here, right? To be able to say, I don't know, is contingent on the psychological safety that's perceived by the learner, by the trainee at that specific point in time. For those of you that love HBR articles or really steep into the organizational psychology world, a lot of the work here has come from Amy Edmondson, really great book, The Fearless Organization, who defines psychological safety as the belief that one will not be punished or humiliated for speaking up with ideas, questions, concerns, or mistakes, and the team is safe for interpersonal risk-taking. So it's really easy to go to a curriculum and bake things in and assess things longitudinally and evaluate our program. And we are evaluating it through the Jefferson longitudinal study. And we're tracking residents as they graduate in their residencies and talking to program directors. Hey, how's Maria doing? Hey, how's John doing? And then we do this formally in our longitudinal study. But to address the psychological safety in the clinical learning and working environment is a little bit more complex than it is to revise a curriculum. What I love 2x2 matrices just because I'm really nerdy. Amy Edmondson introduces a 2x2 matrix of thinking about psychological safety and thinking about the motivation of our learners and how accountable we hold them, and really posits that to really get them in the sweet spot of learning, there not only needs to be psychological safety, the safety to do exactly what was on the previous slide, but the permission to give our learners accountability and to keep them motivated. Tim Clark has built on Amy Edmondson's work and talks about the stages of psychological safety that your environment might be in, right? And he defines them as a safety to feel included, the safety to learn, the safety to contribute, and the safety to challenge, right? So here they are a little bit more specifically, right? But inclusion safety, right? To know that you're valued. Are people welcome for who, what, how they bring themselves to the team, right? Is there learner safety to ask questions, to experiment? Is there collaborative safety? Do they feel supported? And is there challenger safety? Can they speak up? Can they express their ideas? Can they challenge a status quo? Can they advocate for their patients? And can they do so openly? And our next study is really focusing in with a laser focus on the psychological safety that our clinical learning environments are affording our learners. But our overarching goal is to really try to reduce the complexity and the distress by making our learners feel prepared. This, for those of you that like Medical Teacher, 12 Tips is one of my favorite article series, and Arabella Simpkin, who's at Harvard, has really thought about this for a very long time. I believe she's a pediatrician by training, trained at NHS, is in the US and does a lot of work and put together these 12 tips. But I think the first thing that we all need to be doing as educators and modeling this behavior is to really reflect on our relationship with uncertainty, right? What does that look like? Because our relationship with that is going to influence what we do and how we do it, even if we're not cognizant of it. So this might be an easy first step for that metacognition. Similar to what we do with our students, as you're working through it and modeling that thought process, naming the type of uncertainty you're working through, whether it's prognostic or diagnostic or behavioral or cognitive or emotional, that too is important. We learned in our COVID studies that, we're not alone in engaging the team, and by engaging the team to create that space to ask questions, to rely on your interprofessional colleagues, will, as a byproduct, create that psychological safety. One thing that we're observing is not happening is role modeling, not knowing with trainees. In a room with trainees, in a room with learners, residents, students, are we modeling, well, I don't really know what's going on here, and this is what we need to do to figure that out, right? Or are we relying on crutches like the data? Let's go back to the CAT scan and veiling that uncertainty with more objective information and objective data. This is one of my favorite ones, and that's really valuing and promoting curiosity over certainty, right? There's been a lot of work recently around diagnosis and how we treat diagnosis, and we need a diagnosis, but during times of diagnostic uncertainty, what ICD-9 code do we choose? A symptom-based one, or oftentimes it's the chief complaint one, right? It happens all the time. But should we be moving to a hypothesis more than a diagnosis? Obviously, there are processes in place where we need a diagnosis to sort of make things work within the system. But on the learning side, are there ways that we can do that? So what we've done at our place is in that S bar, yes, we have that handoff that happens, but there's a diagnostic uncertainty checkbox, and we sort of explain, yes, this is the diagnosis that you're seeing. This is the diagnosis that we're kind of grappling with, but this is our hypothesis. This is what we need to know, and this is what we're working through at that point in time. Another way that we're doing this through faculty development is modeling questions and the way that our faculty are asking questions in the clinical learning environment. Right? Are they asking questions that are sort of factual, lower order, convergent questions, right? Or are they asking more divergent, higher order questions, right? Each question, the syntax with which that question begins with, is going to seek different types of thinking. Those why questions are going to get your learners to sort of think about their understanding. Those how questions might get your learners to think about how they can make things happen, right? And those what if questions can get your learners to sort of imagine possibilities. So it's a little bit more kind of fluffy here, but what we did is we took two major, and this is what we ingrain our faculty at new faculty orientation, and we kind of go to departments and we teach this because this was an issue in our medical school. Our students really reported on data that they felt that they were mistreated. There's a lot of student mistreatment. And when we spoke to students to really find out what that mistreatment came from, clearly there was overt, explicit mistreatment, but there were times where students were talking about, well, the preceptor asked me a question in front of my peers that of something that I did not know. And that's not to abandon convergent lower order questions, because those are important to elicit knowledge gaps, but asking too many of those questions successively could be seen as malignant prodding, right? A newer term for a now dated term that we would typically talk about in medicine. So too many convergent lower order questions can be interpreted, can feel like malignant prodding. So is there an opportunity to sort of take these what if scenarios to really bring in that creativity, to really set the stage for that psychological safety? And then we wrapped sort of the educational theory around it. And here's Bloom's taxonomy. But for those of you that have to write LOs, lectures for something, you always go to Bloom to find out what verbs you should use. I do it all the time, right? But there's a Bloom's taxonomy for question generation, right? If you're looking at knowledge and comprehension, well, all right, well, maybe this is a convergent lower order question, right? What is the best medication to use in scenario X, right? Application, right? Divergent lower order questions. What is the differential for this, right? Divergent, more than one answer, but lower order can be easily found, right? Then we're kind of going upstairs, right, to those higher order questions where we get our learners to analyze things. All right, well, after you figure things out with this very complex patient with a cardiac history, considering that we have options A and B and C, after your review of the evidence, what do you think is the best strategy here? Convergent, higher order questions. It is convergent. They're converging on a specific answer, but it's a little bit more higher order in the way that they're thinking about it. And lastly, divergent, higher order questions that get your learners to sort of synthesize and evaluate things. right? So yes, we saw a patient in this scenario, but what if they didn't have access to an outpatient clinic or they couldn't fill their medications? What could we do then? And bringing in these very creative questions that are fun that might be out of our element to do. Now, some of us love to live in certain quadrants. Some of these quadrants require a little bit more thinking and a little bit more planning, but it's a really great way to sort of, travel in different quadrants, specifically as you're dealing with different kinds of learners. So in the previous slide, in the next slide, there's a QR code where we sort of dichotomized lower order and higher order questions, examples, and lead-ins. Sometimes the syntax in the lead-in can help you think of a question itself, but questions that kind of go from lower and higher order, but get you to sort of think about how can we move to higher levels on Bloom's taxonomy. And this is work that I did with Rebecca Jaffe, who's a hospitalist at Jefferson, who is an awesome hospitalist like many of you. So a lot of theoretical, a lot of stuff, shared some research, shared some educational strategies, hopefully connected some of the dots behind the literature of uncertainty and how it remains a really ripe field for research and asking great questions. But I'm hoping that there's some clarity on the complexity and the uncertainty of the clinical work, some frameworks that can come to mind that we can rely on as we make sense of this, and collectively brainstorming on some educational experiences that can help our trainees for a clinical workplace that is only getting more and more complex. So I think that's all I have, and I would love to entertain any questions and maybe get some feedback on how you manage the uncertainty or do that as an educator.
You have time for one question, then we'll volunteer anybody that wants to come forward to discuss with our speaker. You can come down after. We'll take one question.
I'm the only one asking?
I'm sure lots of people have questions.
My name's Gonzalo, and I'm an infectious disease specialist.
Hi, Gonzalo. Nice to meet you. Thank you.
So several years ago, I was getting more and more frustrated with the gazillion consults we get for chronic fatigue, chronic mind, et cetera, et cetera. It's actually relevant. So I did a literature search on unexplained symptoms. And there's a big body of literature on that published in the United Kingdom, England specifically, where it says, summarized, about 30% of symptoms presenting to ERs, acute care centers, and primary care clinics have no clear explanation. And we better teach people, the learners and doctors, how to deal with that. Fast forward to your presentation, which I enjoyed. How are you going to measure the impact of your JeffMD, curricular change on, uncertainty tolerance? Is that right? How are you going to measure that longitude?
Yeah. So
Do you
again,
mind repeating just a question, just a summary?
yeah. So understanding that a significant portion of patients are presenting without a diagnosis with symptoms that really cannot be explained. How are we measuring the effectiveness of this curriculum in our trainees who will be taking care of said patients in the long term? Which I think is a really great question. Again, this is just my answer. I'm sure there might be better answers in the room, but we're shying away from looking at tolerance of uncertainty and comfort with uncertainty. The AAMC graduate questionnaire would always include a battery of assessments and instruments, including Budner's tolerance of ambiguity. And most recently, it was dropped because the thought process was that one's tolerance, one's comfort is not really predictive of anything. Right. So I could have really high discomfort in dealing with uncertainty, but I could do an okay job because I can appraise it. I know my body's natural reaction to it, and I have a whole bunch of tools that sort of help me with that. So what we're looking for is bringing this back to the MEPOs, those medical education program objectives, those two things, and then having sub objectives to that where we're all bringing it back to, are your learners able to appraise uncertainty, and are they applying specific skills? And in fact, some of the milestones that I shared from pediatrics, which are milestones, which we look for in clinical competency committees, are there. So for our trainees, we have surveys or rather forms that we send program directors of our trainees to sort of fill out and complete, and these are included on them as well. In addition, much like here, I imagine, VCU is a place where students love to stay. It's an amazing environment as I'm learning today. And thank you to all the conversations that I've had. A lot of the Jefferson students that we train also stay with us in our GME programs, and with their permission and their consent, we're able to sort of evaluate them, assess them longitudinally as a means to sort of think about, program evaluation. But we have a detailed program evaluation strategy that's a little bit more messy and nerdy, but it's a great question. We're looking at specific skills application rather than comfort and tolerance for uncertainty. Yeah. Thank you.
Thank you all so much for joining us. Thank you for the presentation.
Thank you.
I'm sure if you want to come down to ask any other questions, please come on down. Thank you so much. Good to see you.